Guys, let's start discussing INI CET RDx questions regarding pharmacology. First question. A 56-year-old male diagnosed with multiple cardiovascular disease was under therapy with multiple drugs like nitroglycerin, furosemide, propranolol, digoxin, and amiloride. He presented to the OPD complaining that he feels difficult in discriminating traffic signals, primarily the yellow and green. Which of the following drug combinations the patient was under has led to this adverse effect? So this question is actually it is going to be very much direct if we target only about the reason for that particular adverse effect. The reason is simple one. The patient is having yellow. The patient is having yellow vision, which means xanthopsia is there. Of course, we know xanthopsia. What is the reason for xanthopsia, guys? Reason for xanthopsia is digoxin. So this is going to be landing up in either option A or in option D. Of course, it is not option B, it is not option C. Now within those, which is going to be the combination? Is it going to be amiloride with the digoxin combination or furosemide with the digoxin combination? Because both are diuretic agents. Again, digoxin toxicity is more prone whenever a patient is landing up in hypokalemia. Digoxin toxicity will be more prone when a patient is in hypokalemia out of both of these drugs as compared to amiloride and furosemide. We know that furosemide is the drug which is associated with hypokalemia. Amiloride is a potassium sparing diuretic. Amiloride is a potassium sparing diuretic, which means it might produce hyperkalemia. Patients might land, even digoxin also produces hyperkalemia. But furosemide, when given with digoxin, there might be a hypokalemia, which in turn might lead on to the toxicity symptoms of digoxin. So this question is primarily based on a digoxin toxicity, which is classically seen in patients who are suffering from hypokalemia. What are the other risk factors? If a patient is presenting up with hypomagnesemia or hypercalcemia, or if a patient is presenting with renal failure or under therapy with a broad spectrum antimicrobial agent, broad spectrum antimicrobials, because that also is going to be increasing the digoxin toxicity, guys. And we have P-glycoprotein inhibitors, especially clarithromycin. All these concepts is going to be increasing the chances of digoxin toxicity. The answer for this question is option D, furosemide with digoxin combination. We'll move to the next question. 68-year-old complaining of tinnitus, lightheadedness, double vision, and thumping feel over his heart. Temperature was 98. Temperature is normal. BP has decreased. The BP has decreased. Physician doubted salicylism but came to know that he was not under salicylate therapy. Which of the following drugs would have caused this adverse effect if not aspirin? Question is which drug, if it is producing an adverse effect that is very much similar to salicylism, that is very much similar to aspirin overdose or salicylate overdose. The question is quinidine, my dears. The answer for this question is quinidine. Why am I saying that is? Quinidine is associated with something called as synchronism. Quinidine is associated with synchronism because quinidine is derived from cinchona bark. It might be associated with synchronism, which classically features patients might land up in tinnitus. Remember this, patients might land up in tinnitus. Patients might have headache, diplopia, or double vision. Some patients might land up in visual abnormalities. It might be anything of it. Patients might land up in palpitation and dizziness. Palpitation and dizziness. A classical feature which they used to use, especially during designing a question, is tinnitus buddy. So if a patient is presenting up with an antiarrhythmic agent and landing up in tinnitus, most probably the reason is going to be quinidine. Why? Because let's look into the other options over here. Captopril is an ACE inhibitor which is associated with angioedema. Captopril is associated with angioedema. Dobutamine is a drug which has got no role with tinnitus and all. Dobutamide is a beta-1 agonist agent. It will produce increased cardiac contraction more than increased heart rate. It is more of a positive inotrope agent. It has got no role with the symptoms which the patient is experiencing. We have atropine. Atropine might be there, somewhat similar ones. It also might land up in symptoms which is similar to this, but the patients will be landing up in hyperthermia. Atropine, anticholinergic drugs, patients might land up in hyperthermia. Here, the temperature of the patient is normal, which means it is not going to be coming under atropine overdose. The answer for this question is clear: quinidine overdose. So what's the next step in management, guys? If a patient lands up in quinidine-induced synchronism, no need to worry. Mostly it is going to be reversible. There is no need to stop the therapy. There is no need to stop the therapy because usually this is going to be reversible in nature. Moving on to the next question. Which of the following text drugs would have caused this adverse effect in a preclinical trial? See, they have administered a drug molecule and they have seen about what exactly has happened to the heart rate and the systolic blood pressure. Previously, it was 84 beats per minute. Now it is a little bit decreased to 78 beats per minute. Previously, it was 130. Now it has been increased. The BP has increased and the heart rate has decreased. Of course, we can rule out from the individual options, my dears. We remember that concepts which we have explained about in autonomic nervous system. Alpha-1 stimulation will produce vasoconstriction, thereby increases the blood pressure. Beta-1 stimulation will increase the heart rate. Patient's heart rate will be increased. Stroke volume will be increased. Also, cardiac output will be increased. Beta-2 stimulation, on the other hand, will produce vasodilatation and decrease in the blood pressure. A basic formula, which we have discussed a lot about that in the regular scenarios. Whenever the BP is getting raised, what can we expect? Reflex bradycardia will be developed. When the BP is raised, there might be reflex bradycardia. And a similar thing, patients might land up in reflex tachycardia when the BP is getting decreased. Now here, epinephrine on the other hand will be having all the receptors activity. It might be alpha-1, beta-1 and beta-2 receptors, for which patients might land up in biphasic response in the blood pressure. Biphasic response in the blood pressure will be seen if a patient is under epinephrine therapy. Let's look into option D. What exactly is metaproterenol? It has got only beta-2 activity. Isoprenaline on the other hand will be having only beta activity. There will be no alpha, which means beta-1 will be there, beta-2 will be there. Norepinephrine has got no beta-2 activity. Norepinephrine has got no beta-2 activity. So the take-home point here is, if you have administered metaproterenol or metaproterenol for this patient, beta-2 activity alone is going to be there. So what will happen to the blood pressure? Blood pressure will just be decreased. There will be no change. Here in the questions which has been given, we can see that the blood pressure has increased. So of course, this is not going to be the answer for that question. And epinephrine also will not be the answer. Why? Because the heart rate tend to rise up because of the beta-1 activity. So here the heart rate has not raised, the heart rate has fallen down. Now what about option C, isoprenaline? Isoprenaline has got beta-1 and beta-2 activity. Let's look into what exactly happens when you administer isoprenaline. Because of beta-2 activity, we can expect a decrease in the blood pressure. What will happen to the heart rate when you administer isoprenaline? Consider this is where the heart rate is. Because of beta-1 activity and beta-2 activity, beta-1 induced increase in the heart rate, beta-2 induced reflex increase in the heart rate. Again, both will join together to produce a very high increase in the heart rate. Heart rate is going to be increased because of isoprenaline. On the other hand, what if you administer noradrenaline for a patient? Noradrenaline has got alpha-1 and beta-1 activity. There will be no beta-2 activity, my dears. There will be no beta-2 for noradrenaline. What do you expect to the blood pressure is going to be? Because alpha-1 is there, beta-1 is there, we can expect a rise in the blood pressure. BP is going to be raised up because of alpha-1 agonistic activity. But the heart rate is where the most confusive factor is. Why? Because alpha-1 will produce reflex bradycardia, whereas beta 1 will produce increase in the heart rate. Because of these actions, always please note that the reflex mechanisms will be overtaking the primary mechanism of beta 1 receptors effect. So what we expect is not a major decrease, we will expect a minor decrease in the heart rate, which will be seen because of the reflex mechanisms associated with noradrenaline. So noradrenaline is the drug which will tend to increase the blood pressure, also tend to decrease the heart rate. The answer for this question is noradrenaline, because noradrenaline has got no beta 2 activity, alpha 1 induced reflex bradycardia, whereas beta 1 induced tachycardia. Because of it, the heart rate will fall down, as I've told, reflex mechanisms will overtake, but not that much as compared to your beta 1 receptors activity. That's why there will be a mild decrease in the heart rate will be seen for noradrenaline. Moving on to the next question, my dears. A 38-year-old female who is a known case of epilepsy was under therapy with clonazepam. We know about clonazepam. Clonazepam is a benzodiazepine for more than 5 years. She was brought to the emergency by her relatives, stating that she has taken high doses of clonazepam due to her suicidal thoughts following a family issue. Which of the following statements is true regarding the treatment for the patient? Of course, this patient is suffering from benzodiazepine overdose. Yes, this patient is suffering from benzodiazepine overdose. We know the antidote for benzodiazepine is flumazenil. So this question is not regarding those particular topic. That is in one-liner. We are not going to be designing that. Here the question is regarding the dosage levels of flumazenil. We went a little bit upwards. What exactly is the dose of flumazenil to be given? Whether it should be given as high doses or very high doses, or at high doses or at low doses. And how the dose is going to be titrated. Flumazenil dose to be titrated at frequent intervals, or no need for dose titration, titrated at prolonged time intervals, or dose again titrated at prolonged time intervals. We'll look into that. If a patient is landing up in benzodiazepine overdose, we can classify them into two major subtypes. Those patients who have presented without any tolerance development, or with tolerance development. Because we all know benzodiazepines has the capacity to produce dependence, tolerance. Also, patients might land up in withdrawal seizures. We have discussed about three major points in our sessions itself. So benzodiazepines, if the patient who has taken up benzodiazepines already who have not landed up in any tolerance of it. Some patients would not be under long-term therapy with the benzodiazepine. They would have taken it. Those patients would have taken benzodiazepines. They're not having any tolerance development for benzodiazepines previously. But this patient is under long-term therapy. This patient is for more than 5 years is under clonazepam therapy, which means tolerance is going to be developed for it. We have one more condition. With or without history of seizures. Without history of seizures or with history of seizures. This patient is landing up in that second category, but the patient is a known case of epilepsy under therapy with benzodiazepine as a long-term therapy, and the patient has landed up in tolerance development of it. Now the patient has taken too much doses of benzodiazepines. How to administer flumazenil? See here, for both of these cases, we can administer flumazenil. For both of these cases, we can administer flumazenil, but the flumazenil dose which we give for those patients who have developed no tolerance to benzodiazepines or who have no history of seizures is we start them at 0.2 milligrams. IV slow push. We have to start them at 0.2 milligram IV slow push. On the other hand, if a patient has developed tolerance or if the patient has got a known history of seizures, because clonazepam patient is therapy because of the seizures. So what you do is patient has taken too much dose of benzodiazepines and you administer flumazenil, patients might land up in withdrawal seizures. That's why this is usually not recommended. Flumazenil is usually not recommended because patients might land up in withdrawal seizures. That's the reason, even if you want to administer flumazenil, we have to start at extremely low doses like 0.1 milligram via IV. So we have to start it at very low doses because to prevent precipitation of a seizure on table. So whenever a patient lands up in benzodiazepine overdose, we have to have a clear-cut history of what exactly this drug, where did she get that drug? And if the patient has taken as like a long-term therapy with benzodiazepines, it is better not to administer flumazenil. Even if you administer it, we have to administer it at extreme low doses because it might induce a withdrawal seizure. If a patient is not under any therapy who is naive to benzodiazepines, they have taken high doses of benzodiazepines, we can administer flumazenil. That will not produce because tolerance has not been developed in those cases. Are you there with me? So 0.2 milligrams is given as IV slow push for patients who have not developed any tolerance. 0.1 milligram, or simply we can start at low doses. And also dose titrations. We can increase the doses. We can increase the doses every 2 minutes. Slowly we can increase the drug dose from 0.2 to 0.3, 0.3 to 0.4, 0.5. Slowly we can increase the drug dose which is being given. Whereas here we can go for titration. We can go for titration, but it should be done every 10 to 15 minutes. So titration should be done with prolonged time intervals. Titrations can be done with shortened, frequent time intervals for a patient without any tolerance. But with tolerance, we have to titrate it with the prolonged time intervals. So that's the treatment regimen for a patient with benzodiazepine overdose. So BZ overdose is an important question. But within benzodiazepines, how are we going to be subcategorizing it? So whether the patient is tolerant to benzodiazepines or non-tolerant to benzodiazepines. The answer for this question is flumazenil is started, option D, flumazenil is started at low doses and dose is titrated at prolonged time intervals to prevent withdrawal seizures. Beautiful. Moving on to the next question. Promethazine was administered for a baby 14 months of age to sedate the baby while traveling abroad on a long flight. What can be expected in the baby? Please understand this, my dears. Children who are less than 2 years of age usually are resistant to motion sickness. They will not develop motion sickness. Children who are less than 2 years of age, usually they will not be landing up in motion sickness. For motion sickness, there is no need for any therapy. If you land up in promethazine, if you give promethazine, there is more chance that which drug has got anticholinergic and antihistaminergic property. Promethazine is a drug which has got both anticholinergic and antihistaminergic property. Because of it, these drugs will tend to cross the blood-brain barrier and tend to produce apnea and respiratory depression in the children. Well, that's the reason this drug is usually not administered for children who are less than 2 years of age. And it can be given if a baby is more than 2 years of age, we can give promethazine. But less than 2 years, it is usually not given because it might induce apnea or it might induce respiratory depression. How do we treat or prophylaxis of motion sickness in terms of adults? We go for scopolamine patches. Mostly the treatment for motion sickness is very much unsatisfactory. Prophylaxis is always a better option for treatment. Good. Moving on to the next question. All of the following drugs are more prone to cause amyloid-related imaging abnormalities. ARIA. Amyloid-related imaging abnormalities in MRI brain except. See, what exactly is this ARIA? These are imaging abnormalities. Either it might be showing an edema or it might be showing a hemorrhage. Either there might be an edema or a hemorrhage. This is called as ARIA E and ARIA H. These are commonly seen with the monoclonal antibodies approved against Alzheimer's, especially which are targeting the amyloid deposition. For example, we have solanezumab, we have aducanumab, and we have baptinuzumab. These three drugs are approved against Alzheimer's targeting amyloid molecules. So these amyloid-related monoclonal antibodies, if it has been given and the patients might develop, when the patient has been coming up for follow-up, MRI brain might evoke an edema or a hemorrhage, which exactly means amyloid-related imaging abnormalities. But on the other hand, here the question is an except question, buddy. It's a negative phase question. They're asking about which drug will not produce that. The answer for this question is going to be galcanezumab. The answer for this question is going to be galcanezumab, because galcanezumab is an anti-CGRP monoclonal antibody. Galcanezumab is an anti-CGRP monoclonal antibody approved against migraine. Well, this is the only odd man out, and that is the answer for this question. Moving on to the next question. A 29-year-old complained of constant thirst and increased urine output. He was under lithium, that's it. So first diagnosis we have made, lithium, and the patient is under constant thirst and urine output, which means this is a case of lithium-induced diabetes insipidus. Which of the following would have been the mechanism behind it? How lithium-induced diabetes mellitus is being developed? Blockade of sodium reabsorption, blockade of cyclic AMP, increased plasma glucose, decreased insulin secretion secondary to lithium. I will explain that, my dears. Consider here is where your distal convoluted tubule or collecting duct is. Tubular epithelial cells. On the right side we have the urinary lumen, left side we have blood. What exactly happens? Sodium which is present in the urine will be taken up inside the presynaptic terminal. Sodium which is present in the urine will be taken up inside the distal convoluted tubule, epithelial cells. And this sodium, with the help of, how it is going to be taken up? With the help of ENaC. Yes. ENaC, we know that epithelial sodium channel, which is responsible for reabsorption of sodium from the urine. Good. Especially in DCT and collecting duct. This sodium cannot be stored up inside the epithelial cells. It has to be reabsorbed back inside the blood vessel. For it reabsorption to be happening, we have a specific transporter here. With the help of this transporter, sodium will be taken back inside the presynaptic terminal or presynaptic. The sodium will be taken up back inside the blood vessels. In exchange with, you would have known it, in exchange with potassium. In exchange with potassium, potassium again is going to be let out inside the urine. Potassium is going to be let out inside the urine. This is the mechanism of how aldosterone is producing its effects. Aldosterone, what's the function? It takes in sodium and lets out potassium. This is the mechanism of it. This pump which we have written over here, this pump which we have drawn is called as SPAP, sodium potassium ATPase pump. We have two important channels involved here. The first one is called as epithelial sodium channel, responsible for reabsorption of sodium from the urine inside the epithelial cells. Next one is SPAP, sodium potassium ATPase pump, responsible for taking in of sodium from the epithelial cells back inside the blood, letting out of potassium. Well, this whole process is taken control of by the aldosterone, mineralocorticoid. But the point here is, the same area, in the same DCT and the distal convoluted tubule, we have antidiuretic hormone. When the antidiuretic hormone is getting secreted, it will bind with its own receptor which is present on the DCT and collecting duct. And this is a V2 receptor, which is a GS receptor. Antidiuretic hormone will be stimulating this V2, which is a GS receptor. GS means we know it is going to be increase in the intracellular cyclic AMP. When the cyclic AMP is getting increased, this in turn will be increasing the synthesis of a certain protein. One of the protein is what we call as aquaporin channels, and that protein is called as aquaporin channels. With the help of this aquaporin channels, water which is present in the urine is going to be reabsorbed back inside the tubular epithelial, thereby into the blood vessels. Water is going to be reabsorbed back inside the blood vessels. This is the mechanism of how antidiuretic hormone is producing its antidiuretic actions. It increases the reabsorption of water from the distal convoluted tubule and on the collecting duct. Okay, this whole process is happening where? In the DCT and the collecting duct. Now the patient is under which drug therapy, my dears? As we have seen over here, lithium therapy. Now what happens whenever lithium gains entry inside the urine, that is also a single positive charged molecules. This also will be attracted towards the epithelial sodium channel, Thereby that also will be taken up inside the epithelial cells. Through the epithelial sodium channel, through the INAC, the lithium also will be reabsorbed back inside the epithelial cells. Now lithium is there inside the epithelial cells. But unfortunately, lithium cannot move back inside the blood vessels because it is not a good substrate for SPAP. Lithium is a good substrate for INAC. Lithium is not a good substrate for SPAP. So now what happens? Lithium from the urine is taken up inside the epithelial. It is not moving back inside the blood. Lithium will be accumulated there inside those epithelial cells. When the lithium is getting accumulated, this will inhibit the cyclic AMP. When there is too much concentration of lithium, it will inhibit cyclic AMP. Thereby, it will prevent the aquaporin channels from getting synthesized. If aquaporin channels are not getting synthesized, water will not be reabsorbed. If water is not reabsorbed, water will be excreted out in the urine. This is the mechanism of how lithium induces diabetes insipidus. Lithium induces diabetes insipidus. So what is the primary mechanism of how lithium is gaining entry inside those epithelial cells? By INAC, block it. Treatment of choice for lithium-induced diabetes insipidus. This can be treated with amiloride. This can be treated with amiloride because that is an INAC blocker, epithelial sodium channel blocker. This is the whole mechanism of how lithium is inducing diabetes insipidus. So the answer for this question is, it blocks cyclic AMP in distal convoluted tubular epithelial cells. This is the mechanism behind it. Clear? Moving on to the next question, my dears. A 9-year-old who is constantly bedwetting, diagnosed with nocturnal enuresis, was administered imipramine. Usually we don't administer it, but it was administered for the patient. He was responding well to the treatment. He was brought to the emergency after 5 days, stating that he accidentally consumed multiple tablets of imipramine. What exactly is imipramine? Imipramine is a tricyclic antidepressant. So this patient is landed up in TCA overdose, tricyclic antidepressant overdose. What are the classical features of tricyclic antidepressant overdose, my dears? I hope you remember that tricyclic antidepressant overdose, 3 C's will be there in the mnemonic. C is for coma, patients might land up in convulsions, and patients might land up in cardiotoxicity. Why is there a cardiotoxicity? Because these drugs are acidic drugs, patients might land up in acidosis. So the reason for cardiotoxicity is acidosis. So the treatment for that is we can administer sodium bicarbonate via IV route. Why? Because this drug will prevent the acidosis from happening. It will increase the pH. It will raise the pH and also it will increase the sodium, which will prevent the tricyclic antidepressant overdose or cardiotoxicity from happening. And because it is rising the pH, it is neutralizing the drug also. It is rising the pH, it also neutralizes the drug. It also neutralizes the drug. We can administer isotonic saline. We can administer isotonic saline if a patient is suffering from hypotension. Fluid infusion would prevent the hypotension from developing. And if a patient is landing up in seizures, yes, convulsions, we have to treat the patient. The drug of choice is going to be benzodiazepines, like lorazepam can be administered. Please note here, the sodium channel blocker drugs are contraindicated. The sodium channel blocker drugs are contraindicated because this is the concept of it, right? When you block the sodium channels, it might further blockade, it might further worsen the conditions too. That's the reason why we don't give sodium channel blocker anti-epileptic drugs. We instead give benzodiazepine drug to treat the toxicity associated with the TCA. So with this knowledge in mind, we'll go to the options. The question is actually, all of the following can be used in managing this patient except is there in the question. First look into what are the things which can be used. Till now, what have we understood, buddy? Sodium bicarbonate is there. Yep. Lorazepam is there. Yep. Is there anything else which can be given for the patient apart from those? Phenytoin and procainamide, these are all sodium channel blocker drugs. It should not be administered. Phenytoin is a sodium channel blocker anti-epileptic drug. Procainamide is a sodium channel blocker anti-arrhythmic agent. Both of these drugs are contraindicated. What is flumazenil? We have discussed that. Flumazenil is a benzodiazepine antidote. When you administer a benzodiazepine antidote, it itself might induce seizures. You remember that? Withdrawal seizures, we discussed that few questions before. It itself might produce seizures. Flumazenil also is not administered in those patients. What about physostigmine? Physostigmine is an acetylcholinesterase inhibitor. Acetylcholinesterase inhibitor. If we inhibit the metabolism, guys, there will be too much amount of acetylcholine accumulation. This acetylcholine itself might produce cardiac arrest. It itself might produce cardiac arrest. That's why physostigmine is contraindicated. Why are we saying that in specific? Why? Because tricyclic antidepressants inbuilt has got anticholinergic properties. Tricyclic antidepressants inbuilt has got anticholinergic properties. So we tried giving acetylcholinesterase inhibitor so that the anticholinergic properties can be overcome, but it was in vain. A patient landed up in cardiac arrest. So it should not be administered in a patient with a tricyclic antidepressant overdose. So with this question, you have to understand what are all the drugs to be given and exactly contraindicated for tricyclic antidepressant overdose. So the question is about all of the following can be used except option 1, 4, 5 and 6. The answer for this question is option A. 1, 4, 5, 6 should not be administered for this patient. We can administer sodium bicarbonate and we can administer lorazepam for treatment of the seizures. The next question. A postoperative patient presents with decreased response to painkillers, which was given for her, that is morphine. So physician decided to administer pentazocine in addition to morphine. What can be expected in this patient body? See, consider here is where a cell is. We have the mu receptor which is situated there. The patient was administered morphine. Morphine tend to bind with this receptor. It serves as an agonist agent. When you administer an agonist, it is responsible for pain or it is responsible for analgesia. It induces analgesia. Good. But when the same patient is been administered, is been added, no? I think it has been given, yeah, decided to administer pentazocine in addition to morphine. So when you administer pentazocine, this is a partial agonistic agent. Pentazocine is a partial agonistic agent. When you administer that, we know that partial agonistic agents tend to have more affinity with the receptor as compared to your morphine, guys. As compared to your agonistic agents, partial agonistic agents tend to have more affinity with the receptor. So if it is binding up very much strongly with the receptor, what exactly happens? It is a partial agonist. It will not be producing maximal analgesia, only minimal analgesia will be there. But at the same time, because we have given pentazocine, morphine cannot bind with it because morphine is an agonist. Because if you give a partial agonist, it has got a stronger bind, my dears. The agonist cannot bind with those receptors. Because of this, there will be decreased analgesia symptoms. The analgesia will be decreased in the patient. The answer for this question is option C, decreased analgesia. The concept here is when you give an agonist agent and as an additive therapy, if you add a partial agonist agent, the action of the agonist will be blocked. And partial agonistic agent is going to be minimal, not up to the maximal, which we are going to be decreasing the responsiveness of that particular drug. It is purely based on a single one-liner, my dears. A partial agonist agent in presence of a full agonist agent behave as a competitive antagonist agent. A partial agonist agent in presence of a full agonist agent, that drug will behave as a competitive antagonist agent. It will prevent the binding of the agonist molecules to the receptor. Clear? A 36-year-old patient under therapy for XDR-TB got an ephedrine containing over-the-counter medication for her upper respiratory tract infection. After 2 days of therapy, she developed pounding headache and giddiness. Her BP was very much high, hypertensive emergency. Which of the following drug would have caused this symptomatology? See guys, please note that. Consider here is where the presynaptic terminal is and we have postsynaptic terminal. I will keep it as simple as that. So in the presynaptic terminal, consider we have two molecules of noradrenaline. We have two molecules of noradrenaline in the synapse. When the impulse comes down from the brain, these two molecules are getting released out. So we have two norepinephrine which is released into the synapse. This will bind with its receptors. It will bind with the receptors which is alpha 1. Because of it, there is going to be vasoconstriction. Good. But how the action of noradrenaline is getting stopped? With the help of reuptake. Noradrenaline is going to be reuptake back inside the presynaptic terminal. We have two molecules of noradrenaline which is present in the cytoplasm. Inside these areas, we have monoamine oxidase enzymes which will break down one molecule of norepinephrine. So how many molecules do we have? We have only one molecule. So what happens? This molecule will gain entry inside the synapse. It will be stored again back inside the synapse. What about the other vesicles? New noradrenaline will be synthesized there. New noradrenaline will be synthesized. This is what happens, guys. So again, what happens? We are maintaining the amount of noradrenaline which is going to be stored inside the vesicles. Now, when you administer a monoamine oxidase inhibitor, what happens? Because this enzyme is getting inhibited, what will happen? Instead of two molecules are there, one molecule is getting broken down and that one molecule is gaining entry inside the vesicles. So instead of this one noradrenaline gaining entry inside the vesicles, now we have two noradrenaline which is gaining entry inside the vesicles. So slowly the noradrenaline which is stored inside the synapse is getting increased and increased and increased. But this patient is administered one more drug along with it, and that is ephedrine. What exactly is ephedrine? Ephedrine increases noradrenaline release. That's it, a deadly combo. By one way, you inhibit the metabolism of noradrenaline. By other way, you are increasing the release of noradrenaline, which produces more gush of release of noradrenaline, more interaction with alpha 1, intense vasoconstriction leading on to hypertensive emergency. Patients might land up in hypertensive emergency. So why are we talking about monoamine oxidase inhibitor over here? Here they have given only ephedrine. Here is what the take home point is. The anti-tubercular drug which has got intrinsic monoamine oxidase inhibitor property is linezolid. Linezolid has got monoamine oxidase inhibitor property. It should not be administered with ephedrine or any other drug which tend to increase the noradrenaline release. Clear, guys? Moving on to the next question. A 56-year-old was admitted for surgery under general anesthesia. He was pre-medicated with midazolam. He was administered midas. For intubation, succinylcholine was administered. It was maintained with the pancurone. Which of the following antibiotics, if administered for this patient preoperatively, would not prolong his skeletal muscle relaxation? We have gentamicin, colistin, clindamycin, and piperacillin. Please note that we have some drugs which might worsen skeletal muscle contraction, which might produce neuromuscular blockade. Drug which might induce neuromuscular blockade. Of course, a famous mnemonic, you would have known it from our sessions itself, Amitabh's MCQ. Amitabh's MCQ, remember blood pressure. This is the mnemonic for that. Amitabh's MCQ, BP is the mnemonic for that. From the way Amitabh's MCQ, you will remember that this mnemonic is also for myasthenia gravis or neuromuscular blockade. AME is for aminoglycosides. M is for morphine. We have morphine and magnesium. C is for curare drugs. Curare drugs like the pancuronium which was administered for the patient. Cane drugs which are local anesthetic agents. And colistin which is the antibiotic. One more drug is there which is clindamycin. Colistin, clindamycin. Q is for quinine, quinidine, quinolone, and fluoroquinolones. Quinidine, quinolone, and fluoroquinolones. BP, B is for botulinum toxin. B is for botulinum toxin, and P is for penicillamine. P is for penicillamine, the drug which is approved for Wilson's disease. So all these drugs are tend to producing, will tend to cause neuromuscular blockade, guys. So that's the reason these drugs are contraindicated in a patient with myasthenia gravis. So here the question is regarding which of the following drug would not prolong his skeletal muscle relaxation. This question is clearly a negative phase question. We have gentamicin, that is aminoglycoside. We have colistin, which is there in the mnemonic. Clindamycin is there in the mnemonic. The answer for this question is going to be piperacillin. Piperacillin can be administered post-operatively or even during the surgeries because it will not prolong his skeletal muscle relaxation. Good. Moving on to the next question. A patient diagnosed with BRAF mutant metastatic melanoma was planned to be administered dabrafenib. But due to increased risk of adverse effects and resistance development, trametinib was administered along with the dabrafenib. Which of the following adverse effect risk can be decreased by administering it with trametinib? What exactly is this, guys? Consider we have the cellular membrane. On the membrane, we have the HER1 or epidermal growth factor receptors. We have the epidermal growth factor receptor, HER1 receptor. When that is getting stimulated by the epidermal growth factors, there is going to be stimulation of intracellular tyrosine kinase, which in turn will be stimulating a pathway called as RAS, RAF, MET and MAPK pathway. MET and MAPK pathway. This MAPK pathway is going to be sending the impulses inside the nucleus. When the impulses gains entry inside the nucleus, there will be transcription, translation and protein synthesis, which is responsible for cellular proliferation. For some drugs, we have some drugs which tend to inhibit this particular process. Let's look into the primary one. We have some drugs which tend to inhibit the RAF. RAF will be inhibited by a rafenib. That's it. That's what the drug's name is. We have dabrafenib drug which inhibits RAF molecules. But unfortunately, dabrafenib, there is increased chances of resistance developments. Increased chances of resistance, and patients might land up in cutaneous squamous cell carcinoma. Cutaneous squamous cell carcinoma. To prevent this, how do we prevent it? We add it with the drug called as trametinib. We add it with the drug called as trametinib. As the name itself contains, metinib is the drug which inhibits MET. It's a MET inhibitor, whereas dabrafenib is a RAF inhibitor. We administer both of these drugs together because it will prevent the resistance or tolerance development. And number two, cutaneous squamous cell carcinoma, which is an adverse effect of dabrafenib, when given together along with the trametinib, the incidence is going to be very much lesser. So the answer for this question is going to be option A, squamous cell carcinoma. Arthralgia and cardiomyopathy, these adverse effects will be decreased when given along with this adverse effects is going to be increased when given along with the trametinib. When dabrafenib is associated along with the trametinib, increased chances of arthralgia, increased chances of cardiomyopathy, whereas decreased chances of cutaneous squamous cell carcinoma. It can be actually used for lung carcinoma. It can be used for NSCLC. Treatment for NSCLC, we can utilize this combination. We'll move to the next question. Which of the following best explains the drug 4 from the changes of serum electrolyte concentration? What exactly is drug 4? Sodium levels is decreased, potassium is decreased, calcium is decreased, magnesium decreased, chloride decreased, bicarbonate is getting increased. Patient is landing up in alkalosis. It is so direct question, buddy. Patient is landing up in alkalosis. And patient's calcium levels has decreased. I hope you remember that now. Which is called as a calcium losing diuretic. Which is called as a calcium losing diuretic, my dears. Loop diuretics will be called as calcium losing diuretics. And these loop diuretics tend to produce alkalosis, guys. Everything is there in our notes, don't worry. So loop diuretics are calcium losing diuretic. Understand with this number, with this thing which is there in the mind, calcium losing diuretic. We have a calcium sparing diuretic. We have a calcium sparing diuretic which is thiazide diuretics. Thiazide diuretics are calcium sparing diuretics. Well, that's the reason why we have when a patient's calcium level is getting decreased, it might be mostly because of loop diuretics, which has been reconfirmed with the alkalosis which is developed. The answer for this question is going to be torsemide, because that is the only loop diuretic in the options given. Moving on to the next question, guys. A patient under therapy with alprazolam for his sleep onset insomnia was shifted to zolpidem, Z compounds. Which of the following adverse effects should be watched out for if a patient is going to be under long-term therapy with this newer drug? Again, Z compounds are associated with complex sleep behaviors. Z compounds are associated with complex sleep behaviors like sleepwalking and sleep driving. These are the primary adverse effects of Z compounds. This is purely a one-liner, buddy. This is purely a recall-based, one-liner based. It is not problem-solving based. So only if you know that the answer is going to be sleep driving or sleepwalking, you can answer this question. So have this concept in mind. Z compounds might be associated with sleepwalking and sleep driving. Very important adverse effect, a recent one. Moving on to the next question. A 54-year-old female was brought to the emergency with swelling and pain in the thigh. X-ray given below. Which of the following drugs would have caused this adverse effect? A drug which is producing atypical fractures. A drug which is producing atypical fractures, especially over the femur, is dronates. You know about dronates, no? Bisphosphonates. Bisphosphonates, it carries lots of other adverse effects. It might be producing renal failure, renal toxicity. It might be producing osteonecrosis of jaw. But most importantly, they have found out that it produces atypical fractures. That's the reason why it is currently not been recommended by most of the areas. In most of the areas, we are preferring to give RPTH, recombinant parathyroid hormone, like teriparatide and abaloparatide. Currently, teriparatide, abaloparatide is preferred more than dronates because of these atypical fractures which might be associated with those. This teriparatide, abaloparatide itself might induce nausea, vomiting. Patients might land up in hypercalcemia, and some patients might land up in osteosarcoma. Very rarely. It is not a common adverse effect, buddy. This is a rare adverse effect. So the answer for this question is going to be alendronate. Alendronate, which is the bisphosphonate over here, will tend to be producing this adverse effect. Atypical fractures. Remember, it's a very important adverse effect associated with that. The next question. A 50-year-old male who was under therapy with heparin came for follow. Which of the following need not be expected in the patient? What are the adverse effects of heparin, guys? Heparin, we have a mnemonic here, Batao. It's a basic question. Batao is the mnemonic. B stands for heparin might be inducing bleeding. T stands for thrombocytopenia. H stands for hyperkalemia. H stands for hyperkalemia and hypersensitivity reactions. Very rarely patients might develop hypersensitivity reactions. Hair loss will be there, alopecia, and osteoporosis can be expected, which is mostly seen in pregnant individuals. When heparin is given in pregnancy, they are more prone to land up in osteoporosis. Now here, heparin is being given, raised potassium can be expected, decreased platelet, hyperkalemia can be expected, thrombocytopenia can be expected, bleeding can be expected, hirsutism cannot be expected. We expect alopecia when a patient is under therapy with heparin. So that's why this is the answer for this question. The answer for this question is option C, hirsutism. The next one. A known case of chronic obstructive pulmonary disease and hypertension was under therapy with enalapril. On follow-up, his HbA1c was elevated 8.5. Which of the following drugs should be used with caution in this patient? This is an interesting question, my dears. Why? Because the patient is under COPD. There is more chance that patients might land up in metabolic acidosis. Also, patient is under enalapril therapy. Enalapril, on the other hand, is an AC inhibitor that also might be inducing acidosis in the patients. So we have two important areas which might induce acidosis. So in those cases, if you land up in metformin, patients might induce something called as MALA. What is MALA? Metformin associated lactic acidosis can be expected in these patients. So especially those patients who are more prone to land up in lactic acidosis, if you administer metformin, they are more prone to land up in it. Quickly they might land up in lactic acidosis. Primarily seen in terms of renal failure patients when it is given a doses for renal failure, or in chronic alcoholics. Alcoholism. These patients are more prone to develop metformin-associated lactic acidosis, and if a patient develops this, we have to treat the patient with sodium bicarbonate. Again, the same sodium bicarbonate has to be administered to neutralize, to correct the acidosis which is developed because of metformin. Good. The next question. A 54-year-old female suffering from severe postoperative muscle spasm was showing better response to dantrolene sodium. What is dantrolene sodium? This is a ryanodine receptor blocker. Ryanodine receptor blocker. For muscle spasm, ryanodine is necessary for the release of calcium from the sarcoplasmic reticulum. If we block the ryanodine receptors, calcium release will not happen and the muscles will land up in relaxation. Which of the following investigations must be taken on follow? So this is not a question regarding mechanism. This is the question regarding adverse effects of dantrolene. Please note that dantrolene sodium is associated with severe hepatotoxicity. This is question, again a one-liner question, buddy. Dantrolene sodium is associated with severe hepatotoxicity, especially if a patient is under chronic therapy from the 3rd to 12th month of therapy. From the 3rd to 12th month of therapy, they might land up in severe liver enzyme going to be elevated. We have to constantly follow up with the liver levels, and if in case there is any abnormality, we have to change the drug dose. Clear? So remember this, dantrolene sodium is associated with more hepatotoxicity. Moving on to the last question. A 39-year-old female patient diagnosed with generalized tonic-clonic seizures was started on valproate therapy. Patient is under valproate therapy. She reports back with poor control of seizure episodes, and gabapentin was decided to be added to the regimen. What will be the next step in management? See, please note that, guys, valproate is a microsomal enzyme inhibitor. Valproate is a microsomal enzyme inhibitor. When you decide to add phenytoin, or when you decide to add carbamazepine or lamotrigine, if a patient is not responding and you decide to add phenytoin or carbamazepine or lamotrigine, the dose of these drugs must be reduced. Because all these drugs, if it is accumulated inside the body, might induce Stevens-Johnson syndrome. These three drugs, phenytoin, carbamazepine, lamotrigine, are associated with Stevens-Johnson syndrome. That's why, because microsomal enzyme is getting inhibited, these drugs will not be metabolized. These drugs will accumulate to produce toxicity symptoms. But on the other hand, same valproate patient is under, and you decide to add gabapentin or levetiracetam. When you decide to add gabapentin or levetiracetam, there is no need for dose alterations. There is no need for dose alterations because these drugs are excreted unchanged. There is no metabolism associated with this. So, be it a microsomal enzyme inducer or an inhibitor, nothing is going to be happening to the elimination of gabapentin and levetiracetam. But these two drugs are very much important because that is being used in practice right now. So, gabapentin, even if you want to decide to add gabapentin, there is no need to go for a dose change. The same thing applies for levetiracetam. So, the answer for this question is going to be no need to change the dose of gabapentin. Because usually majority have went for microsomal enzyme inhibitor and gabapentin is at low doses. That is not necessary over here because it will not be metabolized by valproate. These are the questions which has been discussed in INI CET RDx exams which happened recently in our DocTutorials website. Thanks so much.